expecting quite a few more people. So, but sort of thanks for coming back and doing the second session for us.
It's all right, no worries.
But I think, yeah, I mean, I think Nisha, I agree. If we make a start and hopefully more people, now they've got the link, will start to sort of filter through.
Cool. Okay. Do you want to introduce anything or say anything to start off with?
No, I think yeah, Chani, I think if you go for it, we can, and I'll just keep an eye and hopefully people will come through.
Cool. I can't see the chat now, my love, so you're going to have to keep an eye on the chat for me. Is that all right?
That's fine. Yeah, no problem.
Cool. So hi everyone. So my name's Chani. I'm here to do the Journey Continue Diabetes Part 2. So we did our first part, I think, last year, where we'd gone through a couple of different parts of the different medicines and things that were there. The importance of trying to get diet controlled, diabetes, and kind of going forward, getting that diet emphasis as well as exercise and lifestyle, which we go and bang on about all the time to our patients. And then I touched on the different medications that are available for diabetes in terms of the oral therapy. I'm going to recap on those kind of particular medicines, and then knowing that SGLT2s are a huge part of everything that we do. Go through a little bit on kind of who we should be starting in, who we shouldn't be, what we should be considering, and then also then going and looking at a couple of case studies where I'm hopefully going to get you guys talking a little bit with me as well, rather than me just talking at you, about what we need to be doing, what we should be doing in some of these patients and applying some of that learning. I'm also going to look at kind of these individualized targets as well, because really conscious that we don't really get told a lot about what individualized target means for a lot of patients. So for that reason, we're going to go through that as well. And I aim to hopefully not be here for 2 hours, hopefully give you guys a bit of time back, she says. So as ever, presentations is intended for educational purposes only, but doesn't replace your independent professional clinical judgment. And any opinions expressed in this presentation on the following slides have been prepared and shared with thanks to any reference sources that are there. And also they can change depending on if there's any change in guidance policies or any protocols. So a recap of oral therapies for type 2 diabetes. Now, this is our lovely South West London guideline in itself, which goes and tells me exactly what we need to be going for when we're looking at type 2 diabetes. So I'm looking at rescue therapies for those people who are symptomatic hyperglycemic. So those people coming in with those osmotic symptoms. So peeing a lot, feeling really thirsty, actively losing weight, losing weight without trying and so forth. So really are going and actually showing that they are on the highest spectrum. We want to be going insulin or sulfonylurea to get those blood sugars down on that front. And then we review that once it's been achieved, followed by looking at if they're not high risk CVD, high risk CVD, or if they've got heart failure or established atherosclerotic CVD as well on that front. So metformin to everybody. And then these have just slightly changed actually going forward, because when you look at those patients, any patient with diabetes is going to have high risk of cardiovascular disease in itself. There isn't going to be very few people who are going to be not high risk. So actually going forward, you probably want to be starting an SGLT2, as you can see, second line, but actually for some of these people, first line as well, which is something I'll touch on later on, which is what NICE is suggesting now. And then you've got consider switching or adding in treatment. So a DPP4, pioglitazone, obviously not in heart failure because it's contraindicated, or an SGLT2 for triple therapy, followed by, again, if we need to, then further intensification going forward. Now, in terms of the treatment options, we went through the Omnius Octet, is what I call it, on that front. So we've got all of these different drugs that work in lots of different areas. And each of these kind of areas in itself will target hyperglycemia separately. And I've written in green where each of these drugs actually works. So I thought, as it's been a while, I'll go through a bit of a recap, hopefully not spending too long on this, but a bit of a recap of where each one of these medicines work, what they actually do, and what we're supposed to be expecting in terms of numbers, in terms of reduction when we're looking at HbA1c as well, because that's what we're kind of looking at long term. We don't look at just blood glucose reduction. We're looking at getting that HbA1c down long term, but also reducing down the cardiovascular risk side and the disease burden that comes with that. So starting off with everyone's favorite, which is the metformin on that front, which is a bigranide family, works on anti-diabetic drugs. And it's the most widely first-line type 2 diabetes drug in itself. And you'll find that actually because it's helping with insulin sensitivity and works to reduce down glucose production in the liver as well, actually tends to be something that even type 1 diabetics will be prescribed to boost up that insulin sensitivity as well. Now, when we're looking at in terms of the mode of action, it works in the 3 different ways on that front. So it works on 3 different places by going and looking at activation of an energy regulating enzyme called AMP kinase. So from your biology days back in university, or from when you were back at doing A levels or O levels, whichever you did. I'm not saying any names or ages on that front. But it goes and works essentially in your skeletal muscle, down in your adipose tissue, and actually in the liver as well to help to go and do what we need to do. And when we go and look at the evidence in itself, because of the UK PDS trial as well, it's shown that actually it has a protective effect on the cardiovascular system, according to the UK PDS. But a lot of the clinical trials out there weren't able to establish if there was or wasn't. But according to UK PDS, there was enough data to say there was some form of cardio protection with metformin, which is why they tend to go down that first line side. And generally speaking, when we're looking at kind of metformin in itself, we know that there's advantages and disadvantages on that front. So when you're going and checking, it's weight neutral, so you're not going to get any weight gain, but because it's helping to boost your insulin sensitivity across the board, and utilization of it in the skeletal muscles in itself, you're going to find that actually it helps to utilize that blood sugar. So you may get a little bit of weight loss going forward. It doesn't increase the risk of a hypose, which is great. There is possible CV protection from CV events, which is even better, and effective HbA1c reduction. So we tend to say between 1 to 1.5%. So when we look at that, that's about, if you're taking it properly at the max dose, that works out to be between 11 millimole per mole to about 16 millimole per mole as well, overall from baseline. So depending obviously on how high it is, because if it's higher, you'll hopefully get a bit more of a reduction. And if it's lower towards target, because it doesn't cause that hypocide, it will get you closer towards that target number as well. So actually works really well. So it does have a good significant reduction. Disadvantages, like anything, has some side effects, and all medications, I would say, go and cause you gastrointestinal infects. This one normally noted to be diarrhea and abdominal cramping, and normally that's dose related. So even if we can get a patient stabilized on 1 tablet of that once daily, it's going to have an effect and give that possible CV protection that's there. So I would be going and saying actively, we want to be making sure we're going and using even that 1 tablet daily. Normally with these kind of side effects, you'll find that they'll tend to reduce down and settle down after about a week, 10 days, normally up to about 2 weeks of being on medication, symptoms trying to settle down. And that's why when you're going through the dose increases in itself, you do them on a weekly to 2 weekly basis. You don't do them that you change them up every day or go straight onto the higher whack doses. We do it slow and steady wins the race on that one. Where if you go and look at the guidance, some people will do it monthly, some people will do it weekly. I tend to say between a week, 10 days tends to be okay. So you go for every week to 2 weeks for a dose increase of 1 tablet at a time. In terms of kind of other things you do aware of, so lactic acidosis, so very rare but a serious metabolic effect in itself on when metformin accumulation is occurring, especially where you've got renal disease occurring. So that's going to be something that we need to be concerned about and going and considering itself. And B12 deficiency. So there is a bit of a fight between the metformin and the B12 being absorbed on that front. So for that reason, you'll probably see in your annual reviews that a lot of pharmacists, a lot of patients will go and have a B12 check as well done every year, just because people aren't going and absorbing vitamin B as effectively on that front. Now, conventionally, it used to be that we would take metformin 3 times a day. Actually, evidence tends to say you could do it even twice a day, and it tends to work just as well. And if you've got B12 deficiency at that time, I would be encouraging that person to be taking that B12 about midday if they're taking it twice a day, because it should be taken away from when metformin is in the GI system, just so that way the patient can absorb those levels going forward, because it will benefit them going forward. So overall, great drug. Good protection overall from what we're seeing from if you're looking at the UK PDS study, which is the biggest study that we had to date on that front back then. And it's definitely worth it if we can go and tolerate it. So even the lowest effective doses are better than no doses. Now, the nucleon on the block, which everyone seems to be talking about, is your SGLT2 inhibitors. And it works as a class of anti-hypoglycemic side, which is actually independent of looking at kind of giving that body a kick on that front. So it works through increased glucose resorption, through the actual kidney and actually works to tackle that, so you're peeing it more out, so it causes more glucosuria, so you're going and peeing it out more on that front. And the key thing being with this is the amount of glucose tends to be going and peed out on that front is going to be dependent on that front of what our GFR is. The better the kidney function we have, the more we're going to be able to pee. But again, it works as a bit of a filter on that front, that once it hits a certain platform, it won't be causing any glucose reabsorption, or very minimal will occur on that front. So for under 45 milliliters per minute, it doesn't do that. So we need to make sure that above 45 milliliters per minute, it works for that basis to go and actually reabsorb, help with that stopping that reabsorption of blood glucose and out into the urine in itself. Otherwise, it won't do anything below 45 milliliters per minute. And the way that it tends to work, for obvious reasons, is because you're clearing the glucose, you're therefore going to have less blood glucose in the system in itself, and it's an insulin independent mechanism on that front. So because of that, actually, because you're clearing that extra glucose through the kidney that's over here, so I should bring it over here, through the kidney over here in itself, when you've got that hypoglycemia, SGLT2, this lowers your blood sugar. So actually it means we're getting better balance happening across the board of these 3 different areas going forward. So generally you should have more insulin sensitivity in the fat in your muscles in itself, better insulin secretion because you're not so overloaded with your blood sugars in itself, and decreased gluconeogenesis. So if you remember from my first session, you have decreased sugar being produced in the liver because you're clearing a lot of that actual sugar that's already circulating. So it puts less pressure on the rest of the body on that front, which works a great treat. And the key thing being for me is that, again, we have to make sure that this binding in itself, although it will occur on that front, it will not clear that blood sugar if it's at 45 milliliters per minute or below on that front. So, but it will give an element of kidney protection, which is something that's found in this particular medicine and with these particular drugs, is it does give you kidney protection and protection for the heart across the board for all of these different areas on the, well, for all of these areas, for the CKD side, as well as for the heart side to prevent heart failure going forward for even below 45 milliliters per minute, all the way down to end stage renal disease. So you want to making sure we are carrying on with those drugs, even if it's not indicated for diabetes in itself. So it's really important that once they're on these medicines, we keep them on it. So you start it, you keep it, and you leave it effectively until your renal physicians tell you we need to be stopping it. Obviously, benefits of this is there's low risk of hypos because, again, it works on that filter below 45 milliliters per minute. It's not going to chuck anything out. But again, once you get to a normal glycemic side, so your blood sugar is normal, it's not going to chuck any of the blood sugar that's a normal level. So it works as a filter to clear any of the extra blood sugar, not your normal blood sugar level. So if you've got normal blood sugar, shouldn't be going to affect you, which is why it's great to be used in your heart failure or your kidney patients as well. Because if you're normal glycemic, the evidence tends to say that actually when you're looking at it, you shouldn't be getting hypos with those particular patients either. Now, the key thing being for me is that there's 2 main players, which is the dapagliflozin and the empagliflozin. Canagliflozin was a good player, but then the MHRA came out with the amputation side. So a lot of people tend to not go for it down that route in itself. At the same time as well, ertagliflozin is out there, but actually doesn't tend to show significant CV effectiveness in protecting the CV side. So for that reason, we don't tend to go down that route either when you're looking at this. So when you're looking at dapagliflozin or empagliflozin, it tends to be dapagliflozin for primary prevention, so where they haven't had any heart disease or heart attack, and empagliflozin for your older and slightly frailer patients, but also those people who've had heart disease in itself. Tends to work in terms of where the evidence sat for those patients going forward in the trials, or who to give what essentially. So the primary and the secondary prevention works a bit better that way. The other thing to go and say as well is that the guidance that's coming through is for CKD as well. So dapagliflozin is licensed, as is empagliflozin, but empagliflozin is not on our formulary yet for CKD. So that'll be something we do later on that. So the key thing being, again, for the advantages, hypoglycemia risk is low on that front, as we said, affected in all stages of type 2 diabetes, and it gives you renal protection for even below 45 milliliters per minute. So again, leave them on it. Associated with weight loss, which I'm sure every diabetic really wants, and consistent with lowering your blood pressure because you're lowering that circulating volume on that. Now, the key thing being is that especially where you've got sugar being peed out, and if sugar is being peed out on that front, you're going to find there's a certain amount of discomfort if you're finding that's very concentrated. So you want to make sure you're drinking more water. If you're not drinking enough water, or you'll find that you're not hydrated enough, the risk of getting genitourinary infections, getting things like, for example, thrush on those fronts can then occur, which then goes and causes issues. And we need to ensure that hygiene down below is kept effectively as well. As you're drinking lots of water, obviously, drinkable water, polyuria, excuse me, polyuria is a big thing in itself on that front. So we want to make sure that they are drinking enough water, but not to the point where they're having to pee constantly. When a medication is started, again, it's normally the first 14 days that the people will go and experience that while the fluid starts to balance itself out. But then it should settle itself down on that front. And diabetic ketoacidosis is a very big risk, but I'll talk a bit more about that a bit later on. The other option we've got is DPP-4s. So when we're looking at DPP-4s, essentially it's circulated concentrations of your incretin hormones in itself. So what does that mean? So they tend to go and DPP-4s will go and increase your effect of your incretin, which is circulating around. Now, what does that actually mean? So basically, DPP-4s work on an enzyme, which is over here. They go and then block that enzyme. The enzyme will break down and then make your GLP-1 go to inactive GLP-1. So the idea of this inhibitor is to block it and to stop this transition occurring on that front. Now, when you've got that in itself, we know that incretin works directly on the gut to go and actually help with our blood glucose side in itself and the metabolism of it going through. So when we've got this active GLP-1, it works on the pancreas to help with the alpha cells and beta cells on that front, which goes and helps with your hepatic glucose production. That then goes and works on your blood glucose when you're fasting postprandial state, and reuptake on that front of the peripheral tissues, which cause your GLP-1 to increase. There's a nice little cycle where it will go and work around the whole thing to go and help to balance it out. So if where your blood sugar goes up higher, it will go and work to balance that out on that front in itself. You want to be going and making sure that you're going and taking these particular patients going forward one step at a time on that front. So when we're looking at these particular patients in itself, generally well tolerated, low increased risk of hypoglycemia, as well as kind of looking at the different agents, and they're weight neutral for DPP-4s. In terms of disadvantages, generally they're modest HbA1c efficacy, possible associations with pancreatitis. So everyone who's got pancreatitis or had pancreatitis should not be started on a DPP-4 or its equivalent, and obviously refer to your SMPCs for individual information. Now, the brother and the sister act, so the DPP-4 is the first one that came through, and then there's GLP-1 analogues in itself, which you'll find there are oral versions as well as injectable versions that you're seeing coming around. So you'll have Rybelsus, which is the oral version, and then you've got the things that are like Ozempic, Trulicity. We used to have things like the Byetta, which is now not as readily available. So the two main ones are your Trulicity and your Ozempic. And thanks to this lovely weight loss side, which a lot of people are going and speaking about, where it makes it a bit more difficult to get hold of. So there's been a lot of shortages on the background on that front. So you've got GLP-1s, which obviously work on your incretin effect. GLP-1 analogs also work on your insulin secretion, also working on your increased glucagon secretions itself, so helps to reduce that down, works down on your hepatic glucose production, also works on your neurotransmitter dysfunction, where it's telling you to go and eat less. And again, that reuptake occurring in your musculoskeletal muscles. So the big thing is that where the DPP-4s work to inhibit that enzyme in itself, they don't work on GLP-1 analogs for the injectables or the oral. They don't work on those particular ones. So they don't break it down on those particular things. So you can't have a DPP-4 and a GLP-1 analog together. You have to stop the DPP-4 on that front because there's resistance to it being broken down. So there's no point in having it. But the key thing being is where we've got the GLP-1 itself, it helps to go and work on your pancreatic cells, so increasing your insulin release, helps to decrease your glucagon release, slows down your gastric emptying, and increase your satiety in your brain because you're slowing down that emptying in there. This is the reason why it's been a big weight loss drug in itself, and why there is a lot of evidence and information that's out there to try and balance this out. So because it's delaying that gastric empty, you're feeling fuller for longer, which means you don't need to eat as much. And then because of that, you've got more energy balance, which is going to be going and actually using up what's in the body already, and then you decrease your body weight. So it tends to go and say nice and simple, but that's how it tends to work going forward. So the balance of the GLP-1s on that front, so low risk of hypos, unless you're giving it with your SU, so your sulfonylureas, your metformin and SU or a basal insulin on that front. Associated weight loss is huge on that front, which is why a lot of bariatric services and things are obviously trying to go and get that working on that front, with Wegovy being the brand that we can prescribe on that front. And then you've got other indication itself, but it's not associated with any increased CV risk in itself in type 2 diabetes. Actually, if anything, when you look at the peripheral vascular data for Ozempic, actually it's got protective effects overall compared to going and causing issues in itself. However, the oral side doesn't come with that CV side. It only comes with the injectables that you get that heart protection. Now, when we're looking at disadvantages in itself, again, because you're working directly on the gastrointestinal system, you can get nausea, vomiting, diarrhea occurring again, and especially if you're eating a lot of sugary based foods, you're going to find it's going to cause issues. Can cause headaches, essentially, where your body is then adapting to that blood sugar intake being less on that front, so not going and affecting. Has been going and been at increased risk with pancreatitis and pancreatic neoplasm. So again, with that cancer side. So you do need to be careful that if anyone's got a cancer history, issues with their pancreas, that they're getting checked out on that front. It's not something we should just be ignoring. The thiazolidines, I can never say this one, thiazolidines on that front. So basically your pioglitazones. We used to have different ones out previously as well. However, because of the risk of sudden cardiac failure, those have been taken off the market, and there's a big MHRA alert with this one as well. Tend to be a really good drug, but for the right patients. So again, tends to work on your islet B cells, also works on your liver, works on your fatty tissue, and also clears that glucose reuptake, helps with the glucose reuptake in the muscles as well. Now, when we're looking at this, actually it's underutilized medicine in the right patients. So what we tend to find is that actually it works on the PPARY gamma gene in itself. And because it works on that, it helps to alter the lipid expression and metabolism and promotes fatty acid reuptake. So if you've got a fatty liver, it will help to clear any of the fat that's there, but it will go and actually mean that you get fatty uptake occurring in other areas. So you may find that your stomach area or your adipose tissue around the stomach area increases, but it will clear it from the liver in itself. So it's great for if you've got a fatty liver on that front. We'll go and work on your skeletal muscles because it's the way it's working on that front. It will go and work on that front in itself, increasing insulin sensitivity, increasing insulin sensitivity in the liver, and obviously you're decreasing your glucose production as well as looking at insulin secretion across the board and helping on your pancreas in itself. And it tends to go and use those free fatty acids that have been shown to help to induce insulin resistance. By having the uptake, it helps to make everything else work a bit better. So by clearing that out of the system and putting it into reuptake, which is where you'll get a bit more adipose tissue at times centrally, you'll find actually it will make the whole rest of the system work a bit more efficiently. So good options for your thinner patients who are younger, absolutely. Could be something that you consider, but one that I would normally hold to a bit later on. Now, when we go and look at this, so low increased risk of hypos, unless you're giving it with hypo-causing drugs, has more durable effect on glycemic controls compared to when you look at SUs and metformin. So when we go and look at SUs, we saw that last session, that actually over time they lose their effectiveness. So in terms of looking at it itself, this has a better long-term aspect on that front. However, when we're looking at kind of disadvantages, we've got to think about weight gain being a huge one because you're going to gain it centrally around the kind of central region. You're going to potentially have fluid retention as well because of this, which can lead to edema and or heart failure. So anyone who's got any form of heart disease should not be on this, as well as increased risk of bone fractures have been noted with this particular drug as well. Now, sulfonylurea, so this is the ones that you're going to be using, again, short term to get you into control. And then you want to get people off these medicines and put on the right medicines on that front. Really well established on that front and work by working specifically on your beta cells by giving them a bit of a punch to say, give us more of our insulin in itself. And literally that. They bind to the SU receptor, which is over here. They bind to your SU receptor on that front. We'll go through so that you can't get any of the calcium exotosis on that front. So you get exocytosis of insulin instead of the calcium going backwards. So because your calcium increases, means that your insulin can be cleared more. So it's giving your basically your beta cell a bit more of a kick. So similar to what digoxin does with the heart, it gives it a kick into your beta cells to say, give me more insulin on that front. So that's how it goes and improves the sensitivity, and at the same time will give you more insulin. So for that reason, it's increasing your endogenous insulin, which is why it's well established and it works very, very well. It doesn't work well long term. So in short bouts, it works well to get your blood sugar down on that front. So it should be used as a short-term rescue medicine in itself. Now, because you're increasing up the amount of insulin that you've got, it will give you a bit of weight gain on that front, but also because you're going and giving it a kick on that front and you're releasing that, it is associated with high risk of hypoglycemia if you're not eating with this. So for that reason, we need to make sure you are going and actually adding into the mix that these patients are at higher risk of getting hypos. So it's really imperative they eat with this medicine to avoid that occurring on that front, because otherwise patients are going to end up with traumatic hypos and really poorly. Now, when we look at kind of generally speaking in terms of insulin therapy, the idea is to kind of mimic what endogenous insulin would be. So this would be for your type 2 diabetics in itself. Most people will just get that basal level so that they go and get that basal, so they have that kind of foundation going through. However, if you've got people whose endogenous release, which is occurring with each of your, for example, with your medicine, each of your meals in itself, they may need a bolus insulin to go with each meal. The idea would be, is if we could, is to try and get these patients on a GLP-1 receptor antagonist and a basal insulin, and that should work really, really well alongside each other to get you a good balance on that front. And that should then go and support going and actually giving you that endogenous release, as well as that CV protection, and at the same time going and balancing patients going and having that basal insulin that they need. So there's lots of different types. So some being basal insulin, so long-acting generally once daily, prandial, which is normally just before your meals, your premix, which is a combination of both, and your basal bolus insulins in itself. So multiple daily injections with a mixture of short and long acting going forward as well. And insulins can be given by a syringe, insulin pen, or by a pump in itself. So it depends on what works for that particular patient. Now, the good thing is that when we're looking at this, then obviously insulin is giving your body exactly what you're not working and what's not working in the first place. So you're giving the most potent anti-hypoglycemic agent that you can on that front. The dosages can be adjusted regularly to achieve your glycemic control, and rapid reduction in blood glucose can be seen as well. May also be initiated at diagnosis if your glucose levels are high enough on that front. Now, in terms of disadvantages, obviously there's that risk of hypos that occurs, which is going to be key, associated with weight gain because it's insulin, so you're getting more of that hormone, and often enough where you're injecting. So if you're injecting in the stomach, you'll get it around the waist. If you're doing it in the legs, you'll find your thighs might get a little bit more fatty on that front. If you're doing the back of the arms, because some people do it on the back of the arms, same sort of thing on that front. And there's going to be a lot of different concerns that people have. So there's going to be obstacles going on in terms of the weight gain and hypo risk, complex regimens which can go and cause issues, going and having to have intensive follow-up for healthcare professionals. More importantly, actually fear of having to inject on that front, and dexterity issues and being worried about actually being able to give that injection first and foremost. Because if we look at them, it's something like this pen on that front. Not everyone is going to be able to hold that pen and inject it into the arm on that front, especially if you've got difficult issues, or into the tummy, if you have difficulties in your all fingers and thumbs. It's about balancing what you need to be able to use on that front, which is why that's very a specialist-led side. So it shouldn't be something that you're dealing with. There should be a diabetes specialist in the practice who's dealing with that. So when we're looking at all the oral anti-diabetics on that front, I thought this table was actually quite helpful on that front. So in terms of reducing your HbA1c, all of them tend to do that. When you're reducing down your weight on that front, your metformin will help you with that. Your oral GLP-1 analogs will help with that, and your SGLT2s will help with that. PIO, SUs, DPP4s do nothing. In terms of reducing your blood pressure, there's only two that tend to work on that. So that's your SGLT2s and your GLP-1 analogs on that front. Low risk of hypos, all of them, generally speaking, apart from your sulfonylureas on that front. Your cardiovascular benefit, so there's benefit in terms of kind of metformin, likely benefit potentially for your sulfonylureas. In SGLT2s in certain ones, and actually I need to put a tick in for your injectable RAs, but not for your oral, which is why I specifically left it there. And in terms of renal benefit, the only one that's going to give you renal benefit overall is going to be your SGLT2. So you can see why they're being so commonly utilized on that front. And when we look at the guidance that comes directly from our lovely NICE on that front, first line treatment is to go and review what's going on that front, and not high risk. Now, like I said, a lot of patients, when we're looking at them, to be honest, are all going to be high risk. The fact that they've got diabetes will mean that they probably have some form of risk factor somewhere. And after 5 to 10 years of them having diabetes, they will become high risk in itself just because they've had diabetes. So anyone with chronic heart failure, established atherosclerotic disease, metformin, or modified release of their GI symptoms, and as soon as metformin tolerability is confirmed, offer SGLT2. So this isn't telling you to recheck the HbA1c. This is saying add in that SGLT2 even earlier. Same thing with, for example, those high risk CVD. So if anyone's got a Q-risk2 of more than 10, or even Q-risk3 of more than 10%, or they've actually got a statin that's in there in itself, for me, the way that I need to look at it, if they're on a statin already, we should be going and putting them on metformin and adding in that SGLT2, which has that proven cardiovascular effect early on. So not waiting for that 3-month waiting on that front. So you want to be going and making sure we're going and assessing. So even if that patient is on that 1 tablet of the metformin on that front, they've had that tolerability, add in that gliflozin early on. And if your metformin isn't working or is contraindicated or they're struggling with it, get them onto SGLT2. Both of them are saying this alone initially straight away on that front. So a person's HbA1c isn't controlled, then you want to be thinking about going and adding in your additional treatments on that front. And when we look at the additional treatments in itself, you've got DPP4s, your pioglitazone, and your SUs. So that's what I tend to look for on that front end as well. So in terms of when you've got a patient with the high thing, so just like that other slide right at the beginning had showed us, we want to be taking it in 1 step at a time. So we want to be going and doing it. The key thing is at any point, if your HbA1c isn't controlled, we add in what we need to. If at any point, if their cardiovascular risk changes, so it increases, you add in SGLT2, or you switch and add them in if their Q risk is more than 10. So if they're on something else on that front. Again, your GLP-1 treatment, if triple treatment is not working on that front, then we want to be going considering GLP-1. So if your BMI of over 35, according to, or adjust according to if they're Black, Asian, or minority therapies. So again, probably 27 is what we tend to go for them. Or specific psychological or other medical problems associated with obesity, we want to be getting them onto GLP-1. Or if they've got a BMI of less than 35, where insulin therapy would have been significant occupational implications, weight loss would benefit them to reduce other comorbidities, that's where we would add in those GLP-1 analogs in itself. Now we talk about personalizing targets and lots of these different numbers always floating around. So I thought this would actually hopefully be a bit helpful for you guys in terms of personalizing the targets for those patients. So generally speaking, either by diet controlled, or a single drug in itself, not associated with a hypo, you want to be aiming for 48. So 48 is your gold standard. So that's where we would diagnose on that front with that person in itself, and that's where we want to be going. So 48 is your gold standard on that front. If you can get it even lower, even better, because that patient's got even better risk stratification on that. If you've got that patient who's getting drugs that are associated with kind of hypoglycemia on that front, you want to be aiming for about 53. And that would be the same thing I'd be saying for your patients who are on insulin, patients who've got ISUs in there, you want to be aiming for 53 to give a little bit of a higher level, just so that they're not dropping too low. For patients who are on 2 or more drugs, generally speaking, you want to be going for 53. And that's what I tend to say. Between 53 and 58 is your sweet spot where you want to be going for. And you want to be relaxing those targets for certain recommendations on that front for a case-by-case basis. Now, a lot of people set there thinking, like, what about the elderly? What about the ones who are going and having issues? So I've covered that for you as well. So when we're looking at the elderly, so new diabetics who are well motivated or diet controlled, again, you're still looking at 48 on that front. If you're functionally independent, so you're able to go and support yourself, get around, do what you need to do, you can go for an average between 53 and 59. I tend to say 58, but you can go to 59, and this is what the ABCD guidelines were showing us as well. If you're functionally dependent and you can tend to, and you need some support on that front, you can go between 53 and 64. So a little bit more leeway on that front to actually continue, because there's a degree of frailty that's going on. Now, within that, there's going to be other subcategories of looking at frail and dementia. Now, for those patients who have got severe dementia or dementia on that front, and they're struggling to go and actually cover what's going on that front, and you've actually got issues on itself in terms of frailty, you don't want them dropping too low. You want them to be aiming for about below 70 on that front, due to their risk of frailty on that front. So that could be your end stage heart failure patients, Excuse me, my throat's getting dry. So maybe your end-stage heart failure patients who may be struggling with that and struggling going forward on that front. Could be your care home or nursing home patients who would be going for that, to shift it just below 70 on that front. And the key thing for end of life care is to avoid symptomatic hyperglycemia. There's no number on that front because we're avoiding them getting symptoms of treatment on that front. So for them, it's going to be just going and trying to control it, then becoming symptomatic for end of life care. So anyone you go and look at that kind of like that magic, there's magic question of, would I be surprised, or the surprise question I say, sorry, of would I be surprised if they're here in a year's time or not? If you would not be surprised they'd be gone in a year, they'd be down the end of life pathway. So for that reason, you'd be looking at symptomatic hyperglycemia control. Now, we said we're going to go over safe initiation of SGLT2s, because a lot of us will go out and do those care home visits, go and see those nursing home patients, go and see those patients who are at higher risk. And for that reason, they need to be started on these medicines. It's best to be in a place where you guys can then initiate. So my first thing is looking at your cautions. So when you're looking at cautions in certain situations, you have to be cautious. It's not a stay away, but it's a caution one. So anyone who's got a past history of active foot disease or ulceration or peripheral artery disease on that front too. People who've had risk of hypotension or hypovolemia or at risk of severe frailty on that front is going to be important as well. At the same time, making sure that patients who are on keto diets, low calorie diets, low carbohydrate diets, because again, that's where it's going to be working through your blood sugar on that front. Patients at risk of acute hyperglycemia, so because of dehydration being a key one. And patients with really high blood HbA1c, so above 86, I would not be starting straight off the bat, because they would then again be at risk on that front of going and getting glucotoxicity, which is where you've got too much sugar itself. You're trying to clear too much out of the system. Your body can't go and balance itself out. So it ends up going into an AKI, causing renal damage, and then your patient ends up really ill. Cognitive impairment, so where they can't actually remember to take the medicine, is a big one. On long-term recurrent course of steroids, people who have potential for pregnancy, if they're not using effective contraception on that front. Severe hepatic impairment, so again, looking at your child's Pew scores, and I would say from a B or above, you'd be wanting to get your consultants involved as well. And people with recurrent UTIs who could potentially have that potential to go and have more on that front. So these are kind of your cautions. You're going to be cautious with these ones. Not say I can't give them to you at all. I've got to be cautious when I'm looking at these particular patients. There are a few people you've got to avoid across the whole board. So avoid in all situations with these patients. So you're acutely unwell, patients who have had DKA in the past, active foot disease where it is an ulcer on that front rather than being at risk, those who've had an eating disorder, and those with excess alcohol consumption, put my teeth back in, or IV drug use, someone who's critically unwell actually on that front. So people who've had COVID, having surgery, a planned medical procedure on that front. People who have, diabetes from other causes. So those include those type 1 diabetics. So we should not be prescribing this for type 1 diabetics on that front, who have LADA or other genetic causes, or including pancreatic disease on that front. They should be staying away on that front. Anyone who's physically is pregnant, breastfeeding, or childbearing age and sexually active without contraception, we should be avoiding in those particular patients. So those are clear contraindications that we should not be prescribing for. So when we're initiating this particular patient, information that we need to give to that patient itself is, in terms of itself, need to ensure that the person is aware of the following things. So discussing obviously the benefit that it's going to give you heart protection, protect your kidneys, and help you to clear sugar through your urine. So the way I tend to say it is it works by going and clearing extra sugar out of your urine. So as you can imagine, we need to make sure that this is going to be working effectively. So you need to make sure that you're drinking enough water. Now, the key thing is if you're drinking more water, you're going to need to pee more. But it's better than going and getting, if you're peeing out sugar, you're going to find that you're going to potentially, if you don't keep yourself nice and clean and hygienic down below, you could go and actually leave sugar there behind, and that can then cause more different genital infections, UTIs or balanitis, or even thrush on that front. So we need to make sure that you're cleaning that area and keeping it nice and hygienic to avoid those things happening. If you drink enough water, generally, because the sugar is going to be diluted coming through, you're unlikely to get any of those issues occurring. You want to be giving them sick day rules on that front, which I'm going to go through in a separate slide. And a key adverse effects being that obviously they need to be aware of Lower limb amputations of usually of toes, so that's specifically for canagliflozin. Going and looking at the risk of DK and euglycemic ketoacidosis as well, and Fournier's gangrene. Now, the way that I tend to go and say it to patients, because if you go and say Fournier's gangrene, they're going to be like, what? When you go and do it, if you keep yourself hydrated, you should actually be able to clear any of that sugar on itself. So your likelihood of getting something like diabetic ketoacidosis is really rare. Tends to be more so when you're actually going and being dehydrated. So if you're keeping your fluids up, you should be fine. And this is where the sick day rules come into their own, because if you're unwell, it's really unwell, we need to stop these particular medicines, which again, I will go through in a minute. Internus Fournier's gangrene, as you can imagine, if you're clearing sugar out down below, it can make you feel a bit sore, can make you feel a bit itchy if you're not hydrated enough. So one, drinking enough water is going to be imperative. But two, if you start getting any irritation, any difficulties on that front going forward, then please make sure that you're going and making sure that you are following through on that front, so that we make sure we're going and get it checked out, make sure there's nothing else going on, and we're following up on that front, because Fournier's gangrene is not going to happen overnight. It's something that would happen over the course of time. So it's something that we can go and prevent if we have any concerns. Making sure they get their foot care. So everyone needs to come and get their feet checked in itself on that front. Okay. On that front. So we need to go and make sure that we're doing it. And then we need to make sure that the importance of hydrogen and hygiene is important, and we're going and following it through on that front. If you're ever concerned about it, you can go onto Forxiga, and actually there's a really nice, lovely little flow chart that tells you, and a tick box exercise that goes and tells you this. So where we're worried about, for example, the DKA. So this is going to be one medicine where we pause it for the time being. So we stop it for the time being and restart it once you're feeling normal. If we're concerned about it, if you've got any of these symptoms, we need you to come back. So you're feeling or unwell, sick, drowsiness or confusion, sweet smelling breath, so like those pear drop sweets that we tend to get, thirst, stomach pains, rapid weight loss, or deep sighs of breathing, then we need to get you checked out and get straight down on that front. Again, with the Fournier's gangrene, symptoms can include pain, tenderness, erythema, genital or perineum issues, fever, malaise. Again, it's not going to be something that happens overnight. It's something that happens slowly. So if you get any of these early on, come back and see us. And I also actually make patients aware that 1 in 10,000 will normally get this. So it's very, very rare it's going to happen, but we need to make you aware of it in itself. Now, in terms of the different doses, when we're looking at it in itself, I thought this was a really handy slide that you might want to just go and keep for yourself. But when you've got this for patients with type 2 diabetes, symptomatic heart failure, and CKD on that front, you'd want to make sure that these patients are started at 10, and you can use it down to 15 ml per min in the UK in itself, and you can carry it all the way down on that front. Patients with severe hepatic impairment, you start them with 5, see how they feel with the 5, and you would increase to the 10. The idea of the 5 is just to make sure that you're feeling well within that on that front. And as you can see here, even if eGFR is less than 15, you carry on unless your kidney specialist says you need to stop. Same thing with empagliflozin, which is why I said there's only 2 real main players on this front. For your heart failure, your kidneys, and for your blood sugar, your empagliflozin can be started at your 10 and go up to 25 if we need to for your diabetes. But for all the other injuries, it just start it at 10 on that front and keep it at 10 on that front for your other reasons. So if, for example, you've got someone who's on 25, who's gone below that 45 milliliters per minute, who's diabetic, you could go and stop that down on that front and stop it down to 10, because it's not going to have any additional benefit at that point. Your canagliflozin for your type 2 diabetic, start at 100 and increase up to 300 if you need to. On that front, I'll be honest, I don't tend to use very much of that just because of the issues that occur with it on that front. And your erdagliflozin, I'll be honest, I haven't used for anyone, so I don't tend to use it. Now, when we go and look at your sick day rules, we said we'd cover your sick day rules on that front too. When we're looking at sick day rules in itself, so when a person with diabetes is not well, unable to eat and drink, some simple rules they can do to prevent deterioration or your DKA in the first place. So in terms of your symptoms, they need to know about vomiting, nausea, abdominal pain, sweet smell of breath, and any confusion, and to seek immediate help, so A&E 999 if they're severe. If not, come to the GP on that front. If you're ill with your diarrhea, vomiting, fever as usual, stop your SGLT2. So if you've got a UTI even, I tend to say, stop your SGLT2 because it'll make you want to pee more, make it more uncomfortable. So stop it until you start feeling better, until you're eating and drinking fluids normally. So until you're back to normal on that front. Restart after you're eating and drinking at least 24 hours and longer if they're acutely unwell. So if they're still unwell but start to eat and drink it, but they've been really poorly, stop it for a bit longer and then restart it once they're back to their baseline. Drink plenty of water, sugar-free fluids to avoid dehydration. Seek medical advice if they're particularly unwell with infection or if illnesses in itself. And if they're going to plan to have any surgery in itself, or they may be advised that they need to be stopped by this particular medicine by the pre-ops surgery team on that front. Key thing I tend to say is sick for a reason. So sick, look at your sugar on that front. So don't stop your sugar, your anti-sugar medicines, but try and make sure you're having sense. Don't stop all your medicines, but your SGLT2s will need to stop alongside your metformin if you're dehydrated. If you're on insulin, don't stop your insulin on that front. Carry on with your insulin because that's going to be giving your body, without causing issues, what your body actually needs. You see, your carbohydrates, make sure you're having adequate carbohydrate intake. So whether that be with a bit of sugary water, a bit of squash, something to keep that going. And K, look for ketones if you're concerned. And it would need to be blood ketones, not urinary ketones. If a person presents to you in the surgery and they're actually acutely unwell, make sure you're checking a blood ketone test in itself to make sure that they're not having any ketoacidosis side as well, where we need to get them into hospital. And more kind of information is here on that front if we've got any concerns. So if we're concerned about diabetic ketoacidosis, hyperosmolar or hyperglycemic state, acute injury, obviously they're straight to hospital. Make sure that you test and manage ketones with their blood if needed, and ensure adequate calorie intake and hydration with fluid replacement. And conditions that tend to go in common cold, influenza, diarrhea and vomiting, UTIs, chest infections, pneumonia, any abscesses, or any injury like a fracture, where a patient needs to worry about potentially going and thinking about this. Just a concern. And we tend to say sick day rules. Actually, people tend to forget that actually there's more than just SGLT2s that we should be stopping. Even in heart failure, this is something that we should be looking at. So I tend to go with the SAD man because it's easier. So your SGLT2s, your ACE inhibitors, your diuretics, your metformin, your ARBs, and your NSAIDs. Those are your key ones. But you have got the damn glucose drugs as well that you can use, which are diuretics, your ACE, your ARBs, your metformin, your NSAIDs. Big different ones being your GLP-1 analogs, which you can stop, which are normally weekly, and your SGLT2s on that front. And they should only be restarted after 24 to 48 hours of being back to normal. That brings us to case studies, where we're going to get you guys to use your brains and me talking less, hopefully, she says. So I've hopefully got a few case studies here to keep you guys going and keep it hopefully a bit more balanced on that front. So the first case study, and I'm hoping you guys can all read this on that front, was I've written SM and it's SB in the talk, but it's the same person. 66-year-old office manager diagnosed with type 2 diabetes 12 months ago. During a routine screen, his grandfather died at the age of 50 and had a heart attack. He lives with his wife, social drinker on the weekends, and tends to have 3 to 4 pints as a minimum. In terms of kind of support information, his retinal screen was normal, foot check normal, new onset of microalbuminuria, but he's asymptomatic, non-smoker, has complained about erectile dysfunction in the past. His HbA1c that we come back with is 77. His blood pressure is 165 over 92. His LDL, so we're looking at that bad cholesterol, is at 3, but it is treated to target and is down by 40%. BMI is 33. EGFR is 62. ACR has come back at 10 on that front, and he's currently on atorvastatin, metformin 1 gram twice a day, and ramipril 5 milligrams. What would you do on this particular patient? And Ellie, this is where I'm going to need you to look in the chat for me and let me know what people are saying. What would you do with this particular patient?
Yeah, so just as well, I've shared a few links in there. So I've shared the South West London guidance, I've shared the NICE guidance, and I've shared the link to the Q-risk calculator as well. So hopefully that will make things a bit easier to guide you rather than trying to remember off the top of your head.
Absolutely. Well, this guy's Q-risk is already above 10 because he's on atorvastatin, so we don't need to worry about that. So what are we going to be going and doing next? What is everyone saying? Hopefully saying something. She says.
There is typing going on.
Anyone? Anything? I
Yeah,
don't
so
bite, I
someone
promise.
suggested an SGL inhibitor.
Yeah, okay. That's an option. Anything
Lifestyle
else?
guidance.
Absolutely. That's a big one. So if I go through, the way I tend to work is, we note this patient is noted to be very high risk of cardiovascular disease. And he's noted to only be on monotherapy. So his individualized target for me is 48 to 53, and actually he was only diagnosed 12 months ago. So we want to catch them when they're quite motivated to want to make those changes, is probably the best way to put it on that front. So we want to be trying to get it and drive it down as low as we can on that front. Absolutely. Whoever said lifestyle advice, absolutely. So weight loss, alcohol cessation, or at least reduction if we can't get him to stop everything else, and get that exercise going as well. The other thing that's really important, actually, his blood pressure is really out of control. His blood pressure, if we go back, is 165 over 92. So it's not just about looking at the patient's diabetes. We need to think about all the other bits and bobs as well. And we need to get that blood pressure down on that front. So getting that blood pressure control is going to be imperative as well. So started him on blood pressure side and down in itself to about 5 milligrams once daily on that front. So yeah, we absolutely did. We got him onto that to get his blood pressure down itself. Now for me, anyone who's got, so the way I tend to look at it, anyone whose blood sugar is above 70 is, I'm a bit like, oh my God, because when we go back to last session, when your blood sugars are above 70, you're at significantly higher risk of heart attacks, strokes, angina as well, to be fair, but of severe kind of disease and disease-related massive comorbidities occurring, and it being those big cardiovascular ones. So we want to be dropping that down quickly as much as we can, very quickly into that particular region in itself. So with this patient, I actually started on glycoside to nudge that HbA1c down for the first 4 to 6 weeks. So we wanted to go and get that down to go and reduce down that patient's risk in itself. Because when it's up in that 70s region or even 80s, we're worried that this person is really struggling, is too high. And their blood, if we think about it, if you've got too much sugar in your blood, your platelets are going to be sticking together more because they're going to attach to your platelets. If they attach to the platelets and stick more, they're going to clump more, and then therefore you're at high risk of it going and clotting and getting stuck elsewhere, or causing sticking to the atherosclerotic buildup and then also causing a thrombus elsewhere. So we want to get that down to reduce down that stickiness risk in itself. And that's how I tend to think about it. If you've got sugar, so when we go and have, for example, Nutella is my favorite one, or jam even on toast. You end up having a bit of jam or Nutella or something in there. Your hands are really sticky and irritated, and they'll stick to things. The same thing happens with our blood and our platelets. Things will just stick, but they stick irreversibly, unfortunately. And where your red blood cells, your HbA1c, your HB's actually got a lot of sugar saturated onto it, because remember, that's what's actually going. If your blood cells are sticking together, they're going to form clots. So we need to get that down on that front. So we added that glycoside to nudge it down initially because he's above that 70 mark. And then for the first 4 to 6 weeks for him. Then I rechecked his blood sugar because, again, remember, half of that HbA1c is going to be attributed to the last month on that front. And it dropped down from that 77 that it was down to 60. And his blood pressure was beautifully came down to 125/76 on that front. I then reduced down his glycoside to reduce down the risk of hypo, and added in SGLT2. So your dapagliflozin for the primary prevention, just like the evidence tends to go and say as well. So that's when I added in that SGLT2 to be on the safer side. Counted obviously on the hydration, DKA symptoms, Vaughan's gangrene risk, the sick day rules and side effects. And I have got a 3-page patient-friendly leaflet. If anyone wants it, I wrote it. You can have it. It's free. It's not going to cost you a single penny. If you want it, please ask Nisha, and I can ask Nisha to email it across to you guys, so that you've got it, so you can give it to any patient. So if you are worried about missing anything when you're counselling patients, it's there. So you can go through and like a tick box saying, oh, I've gone through this, I've gone through this, I've gone through this. And actually it's easy read for the patients as well. I then repeated his HbA1c on that front in 3 months' time. HbA1c came down to 50 from 77. ACL went down from the 10 down to 0.01 because, again, remember, for CKD, It gives that renal protection, so it helps to reduce down that kind of side as well for that kidney side. So our glycoside was stopped and he just carried on metformin and SGLT2. And that's how we kind of do it. But you could start him on an SGLT2. It just may find that because his blood sugar is a little bit on the higher side, he may then suffer more side effects. So it's better to nudge it down a little bit first and then to start the SGLT2, because then it makes them feel a bit better going forward. So as long as it's under 70 is the way I tend to go, you're good to go on that front. Does that make sense, Ellie?
Yeah, that makes perfect sense. I wonder what your thoughts are around glycoside, because I know, myself included, a lot of clinicians are quite nervous about glycoside.
Okay, explain, why are we nervous about glycoside?
I think because, maybe personally, because a lot of my patients tend to be elderly, care home, high risk, high pose.
Absolutely.
It drops it quite quickly, or it can do. I mean, obviously that is the goal when you've got patients with HbA1cs that are through the roof.
Yeah.
But I think it's that sort of risk of safety netting them appropriately to identify that it's suddenly plummeted a bit lower than we like.
And if you're concerned, the best way I tend to say for glycoside is you can always start it on even the half dose and get them to do some home monitoring. So you can start it on the 40, which are going to have a significantly less effect than the 80 would. Or you could start them on, and this is something that I tend to do, you could start them on 80 milligrams with their largest meal of the day. And that will just nudge their blood sugars down as well. That may be enough just to drop it down a little bit and then to go in with the SGLT2. It's about balancing and looking at what you're most comfortable doing. Now, if you're at a care home, nursing home, they should be managing the food side of things. So it should make hopefully life a bit easier with making sure they're taking that medicine with the food side. And as long as they're taking it with food, you're good. They're not going to get those hypos because the sugar and the carbohydrates in the food is going to metabolize. And it's just going to help to control that. It's more for those patients who are by themselves and more by themselves. You've also got the option of going for the slow release side. So you don't need to go for the glycoside as 80, you go for a 30 milligram modified release, which is slow releasing throughout the whole day. That's another option. Or the glibenclamide, 1 milligram, again, is a one-stop shop and is a one dose for the whole day. So there's lots of different options. I go for glycoside because it's the most commonly one that's prescribed. But if you're ever concerned about it, start it on a low dose and get them to have it with that 1 meal of a day and then review their blood sugar readings in, say, a week to 2 weeks and go from there.
Perfect.
Does that help and help to reassure you a little bit?
Yeah, absolutely. I think, like you say, I think we sort of commonly just go for certain things rather than considering the other options that are available. So
glycoside, again, it's a short-term fix, like I said. So we just want to nudge it down, get them on the right therapy and take them off. If you're running high and you're running, this is going to be for those patients who are running it above 70. So if we look at 70, and I have this chart, she says, if we're running at above 70 on that front, so my lovely chart tends to go and say, if you're running at, say, your HbA1c is running at about 75, your blood sugar on average over the course of the whole day is between 11 and 12 on average all day. So if we're adding in a glycoside on that front to that person, it's going to nudge it down probably to about 8 on that front. It's not going to bring it down. And remember, when we're looking at blood sugar being too low, it's 5 to drive and a hypo typically is less than 5. So we're well away from that still. We're just nudging it down a little bit on that front. I'd be more cautious in adding in a glycoside to someone, for example, who's in their low 60s on that front or at 60 dead on, because that will then bring them into that 53 level potentially, because it's going to help to pause that issue and drop it down lower. So if you're above 60, you can quite easily add in that low dose, add in half if you wanted to, add in a whole tablet with the largest meal of the day and review it and see.
Great.
Yeah.
Thank you.
Okay. So is everyone okay with that one? Any questions?
There's nothing in the chat at the moment, but I mean, oh, hang on, someone's typing. Let's see. Feel free to come off your microphones and talk to us.
I don't mind people talking to me, I promise. Shall I go on to the next one and then we can go back to the question in itself?
Yeah, well, the questions come through and it says, why didn't we increase the Ramapril?
Okay, good question. So now the key thing for me is that when we go into this particular patient in itself, you've got two options here. So you can increase the ramipril. That's definitely one option. Let me go back. So here, so we've got two options here. So his eGFR is 62 milliliters per minute. Now, generally speaking, it means that there's reduced kidney function. And if we look at the hypertension side, at 165/92, we're aiming for this particular patient to go and reduce down that hypertension, that blood pressure down to below 140/90 in itself on that front. If we look at the European evidence or the American evidence, it's actually 130/80 because that's better results overall. But actually, because we're looking at 165/92, we want to try and target that systolic a bit more aggressively. And amlodipine, especially as he's over 66, would work better for anyone who's above the age of 55 to reduce that down compared to where you've got potentially an slightly impaired kidney function already there. The ramipril is absolutely an option to go and do that and to reduce it down, but amlodipine has a more potent blood pressure reduction compared to the ramipril increase. So you could increase the ramipril to 7.5 and then up to 10 if you wanted to, as long as their creatinine clearance is staying above a certain level. Because once you go above, and it's creatinine clearance, not eGFR, if you get the creatinine clearance goes below 60 on that front, between 30 and 60, the generally speaking, the maximum dose you should be going for is 5 milligrams when you're looking at this. That's what the BNF tends to say on that front. So you want to be careful that we're not dropping it down too low on that front. So for more potent blood pressure reduction, you want to be going and trying to add something else in. And even the hypertensive guidance tends to go and say, when we look at the hypertension guidance, that tends to say that amlodipine or a calcium channel blocker works better in this group, in this age group in itself, when we're looking at reducing down the blood pressure in itself. So I tried to tackle it using a different vascular side. So by using the RASI system and looking at the calcium channel blocker system, you're targeting two different areas, which helps to reduce down that blood pressure quicker. So it was just as a risk stratification process. But you could, by all means, increase up the patient's ACE inhibitor, and actually that may also help with the UACR side as well. But it's a balance. It was just something I chose to do on the day because it would target two different systems. And if we look at the national hypertension guidance as well, that tends to say that generally people with hypertension tend to need 2 or 3 different hypertensives to get their blood pressure into control. And it worked quite well. So in my history of when I've been doing this, if I add in an amlodipine in someone who's above 60, tend to reduce down their blood pressure control and make it a bit tighter, a bit quicker. Does that help? But you could, by all means, you could do the ramipril as well. There's no harm in doing the ramipril. You just need to recheck their kidney function every 2 to 3 weeks post-dose titration.
Yeah, I think that's thanks
Yeah.
in the chat there. But yeah, I think I've shared the hypertension guidance, but it does sort of suggest you could do either. And as you say, I think it's sort of open to, that history of perhaps why was he not on amlodipine? Has he tried it? Has he had side effects? It's, all these things sort of
absolutely
to think about, don't we?
I think that's the thing. I think normally when we're looking at hypertension for diabetes, you'd always add in that ACE inhibitor first before anything. No matter what the age is, you'd always go for the ACE inhibitor because it gives you that renal protection. Now, if you've got, for example, someone who's coming in and then has really high blood pressure on that RASI, it's going to reduce it down to a certain degree, but it's not going to have such a potent effect if they're up in the 160s, 170s. So likelihood is you can optimize it up, but it's still not going to get you down to where you need to. So you want to be going and balancing it out so you can reduce down that blood pressure better. So adding in that the amlodipine first is normally a better, in my experience. But it's open to interpretation. You can do either. There's not going to do any harm on that front. Long term, someone like this is probably going to need extra hypertensive therapy in itself. I was just trying to go for something which meant he needs less blood pressure. So I knew I'd have to get him back in after, I think it was 4 to 6 weeks to check his HbA1c. And if I did that amlodipine, I'd have to get him in 2 to 3 weeks and then again in another 2 to 3 weeks. So I was trying to balance out, save appointments for the patient as well. Because you've got to think about, can the patient come backwards and forwards as well? And a lot of them don't like being pin cushions, unfortunately. So it's going for what's right for the patient. All good?
Great. Yeah.
Perfect.
No further questions at the minute.
Okay, so next one is Mr. DG, I think, or her Mrs. DG, I think it was. So she's a 45-year-old South Asian, diagnosed 2 years ago with type 2 diabetes. She's a marketing executive, diagnosed with type 2 diabetes after having a heart attack just before the pandemic. Her father died at 54 from a heart attack, and she lives alone and has struggled with depression and anxiety most of the pandemic, like a lot of people did, generally speaking. She's given up to alcohol and she's an ex-smoker in itself. So her retinal screen was normal, foot checks normal, no microalbumin, and she's asymptomatic. So that's a good big tick. Same time, she is an ex-smoker. She has got depression, anxiety, but no noted LVSD, so left ventricular systolic dysfunction post-MI, which is great. Her most recent blood test, so her HbA1c is about 66. Blood pressure about 142/75, so not too much off what we need it to be. Her LDL is at 1.8, which is great. BMI is 28.9, and her EGFR is 83 on that front. In terms of medicines on that front, so it says diabetes medicine, but actually all her medicines on that front. She's on atorvastatin 80, metformin 1 gram twice a day. She's on ramipril 1.25, bisoprolol 1.25, and she was on DAPT, but now she's on aspirin lifelong going forward. So what are we thinking for this lovely lady?
Can you just confirm what DAPT is, just in case people...
Dual antiplatelet. So she was on dual antiplatelet therapy initially, but she's just on aspirin. That's it.
Thank you.
So she was on clopidogrel and aspirin originally. They've stopped her clopidogrel, so she's just on aspirin now.
We've got some typing going on.
Good. Makes me happy when people are typing. They can talk as well.
People are out there.
I'm not alone. That's the main thing. I don't fancy
so
talking
first
to
suggestion then, we've got SGL2 as history of
Absolutely.
cardio event and gives protection.
Perfect. So we've noticed established cardiovascular disease. Absolutely. So the way I always think about it is I break it down. Oh, go on.
That's right. We've just had the suggestion about thinking about pregnancy as well.
Absolutely.
Pregnancy here.
Absolutely. I will add in, she's got a coil in place. So I'm glad someone then said that she has got a coil in place. And this was actually a real patient as well. So all of the ones that cases I brought in are all real patients that I've seen in practice. So I always break it down is where do we stand in terms of not at risk, high risk, established. So we've got that balance, and that's how I tend to do it. And then I will break it down into what are they on? They're on monotherapy. What's the individualized target? So I tend to say, okay, individualized target for her would be 48 to 53 is how I would balance it out. Anything else coming through, Ellie?
Nothing at the moment.
Okay, that's fine. The next thing, as ever, if I can, lifestyle advice. Everyone gets lifestyle advice on that front. So weight loss, because her BMI is a little bit on the higher side. Exercise, if she hasn't already, given a referral to cardiac rehab because she had the heart attack, as well as kind of things to help to boost up her mood as well with that natural serotonin, or free serotonin, as my sister keeps saying to me. The energy exercise gives her free serotonin. Blood pressure is well controlled. It's not too bad. It's a little bit on the high side, but not too bad on that front. But she has got the anxiety and depression. So what I did is actually I went and spoke to our lovely social prescribers and referred her for counselling through them on that front, and consider adding a medicinal therapy if we needed to. So she got referred to them first as a first line for a bit of counselling and support, because especially with diabetics, they tend to find that they think it's a bit of a death sentence at times. That, oh, someone's died from diabetes. They died from this. They didn't die from diabetes. They died from the complications of diabetes. So it's about balancing what's going on left, right, and centre on that front. And very rightly so. Someone said, we start her on empagliflozin, which is the one for secondary prevention, 10 milligrams once daily to control her blood sugar, which is absolutely spot on, and that's exactly what you want to do. on that front. As ever, counsel on the hydration, DKA symptoms, Forney's gangrene, sick day rules, and side effects on that front. And we repeated her HbA1c in 3 months, all the way down to 47. She continued on the metformin and SGLT2, and actually at that point she'd been seeing the counselling on that front. She'd been counselling, had that, and actually she wanted to go and start something like sertraline for her anxiety, which helped to boost up her natural serotonin that was going on. Because of the interaction of sertraline with the aspirin, we also added in some omeprazole to give her some gastric protection, because there is that gastric irritant effect that sertraline can give as well. So if you don't know anything else, if you take anything else away, SSRIs give you gastric issues. So if you've ever got a patient who's on SSRI and they're on aspirin or a blood thinning antiplatelet, whatever, a DOAC, whatever, make sure that you put them on gastric protection, because they will have issues otherwise. And they'll stop that medication because they're getting heartburn-like symptoms in the chest on that front. So make sure that they're aware on that front. Mr. MK, she says. So a bit more complicated. So 59-year-old accountant who had type 2 diabetes now for about 5 years. No family history as he was adopted. Lives alone, but works really hard to try and control his diabetes. But it's getting difficulty because he's getting increasingly frail in itself. Given up drinking and is a smoker for 26 years in itself. So his retinal screening is normal. Foot check slightly reduced, but not massively. He has got microalbuminuria and symptomatic on that front at the moment. He's going on that front for smoker of itself. Worsening history of breathlessness as well. And his echocardiogram showed that he had mild to moderate LVSD with left ventricular ejection fraction of 37. So this should be ringing some bells about a different diagnosis as well. He had his HbA1c at 54, so not badly controlled at all in terms of diabetes. Blood pressure is a little bit high, 148/85. LDL is not too bad, considering he's not going and having any other issues on that front. He's not had a heart attack from what I can see. His ACR is a little bit higher than we'd want. His EGFR is 55, but his NT-proBNP was 2,100. Now, his current medicines are metformin, 1 gram twice a day, sitagliptin, 100 milligrams once daily, and atorvastatin 20, and candesartan 16. What would you do? So the NT-proBNP is telling us there's an element of heart failure going on with that ejection fraction there of being 37. We can tell there's some heart failure going on there. So he needs a bit of cardiology assessment. What would you recommend that the cardiologist would probably be thinking at the same time? And if you're concerned, you can always bounce some advice and guidance off to them as well and say, this is what's going on. Most of the time, they probably want to see him in clinic, but they'll give you some advice about what you can be doing in the interim for their medicines as well. Anything coming through, Ellie, at all?
Yeah, so the sort of the heart failure aspects being picked up there, and I think also then, you know, there's a question mark around other things like possible COPD with the smoking history,
Absolutely,
breathlessness, the sort of the differential diagnoses.
absolutely. And I think that's really key on that front. So for this guy, taking my kind of step-by-step kind of approach, noted to be very high risk of cardiovascular disease because he's not had any CV disease in itself. It's already on dual therapy, so his target should be between 53 and 58. Actually, you know what? Spot on. He's at 54. Laughing, very happy on that one itself. As ever, lifestyle advice is going to be really important to make sure we give him lifestyle, so smoking cessation on that front. And as we've already picked up, his blood pressure is controlled, could be optimized. In light of raised BNP and results, urgent echo confirmed left as heart failure with reduced ejection fraction. Consider starting him on a bisoprolol and up titration, referral to cardiology if you felt competent on that one, because we've already got the heart failure with reduced ejection fraction, and we know that the patients with the best benefit of these ones are the ones who end up on ACE inhibitors and beta blockers, as well as the other now 4 pillars that are there of the MRA and the SGLT2 as well. But actually, you want to be taking it in, and starting him with bisoprolol might help with that, with a bit tightening of that, if you feel comfortable. But if not, referral to cardiology is definitely indicated. Stop that sitagliptin because it's doing absolutely nothing in terms of cardio protection on that front. So we want to be making sure that we're going and doing that to the best visibility, but cautious because he is frail, but it's still safe because there's dual indications here. We've got the heart failure and we've also got the diabetes in itself. So for him, I ended up starting on the dapagliflozin 10 milligrams once daily because of primary prevention, because he's not had any any cardiovascular ACS rather. It's not had any acute coronary syndrome. It's not had any other heart related diagnoses. So for that reason, we started him on that. And because of the heart failure with reduced ejection fraction and slow progression of CKD, with the 4 pillars, started him on dapagliflozin on that front. Again, as ever, counselled on hydration, DKA, Fournier's gangrene risk on that front, sick day rules, side effects. I will also say we had done a chest infection on this gentleman and he was fine and he wasn't known to have COPD. So thankfully, COPD wasn't an issue on that front that we need to worry about, but absolutely completely valid that we would want to go and rule that out as well. Repeated HbA1c came down to 47. ACL was negligible, and he did get seen by cardiology, who started him on all 4 pillars. So he also ended up on spironolactone 12.5 milligrams once daily as well, once he was seen by cardiology on that one as well. So went all in the right direction on that front. Got Mr. AK, who's a 45-year-old accountant with type 2 diabetes. Strong family history, often progressing to need insulin, but he blames his genes. And he doesn't blame his genes with GENES. He blames his genes, the ones he's wearing. So I just thought I'd let you know. He's lives with his family and works really hard to control his glycemic control. He is Muslim and looking to fast at Ramadan on that front. So in terms of looking to go and assess this particular patient, retinal screening was normal, foot check slightly reduced, non-smoker and no alcohol intake, and he's a thin patient. Am I thinking about this? So not your normal patient on that front. He's been told to protect his kidneys. He was told to take Ramipril, so he took it. Is finding that he's needing to pee more often at night, so he's symptomatic from what we're hearing on that front. His HbA1c is 92, and his trend despite intervention, so in 2021 is 64, 2020 before that was 50, and now it's come up to 92 dramatically. Blood pressure is okay, 140/80. Bad cholesterol is okay as well. ACL was negligible. BMI of 23, and his kidney function at the moment is 90. Oh, well, above 90. In terms of diabetes medicines, he's on metformin 500 milligrams twice a day because he couldn't take it the 1 gram. Gliclazide 80 milligrams once daily. Ramipril 2.5 and atorvastatin 70 on that front. What are we thinking about then? Because this is not your typical patient who fits the mold. What are we thinking here with the last 2 sessions that we've done? I'm also going to put in there, he's 45 years old. So he's a young patient, a very young patient who was diagnosed at the age of 39, 40. So just think about that as well. Ellie, anything?
Yeah, so we've just had one come through, sort of, questions around what else could be going on. Something thyroid related, any cancer histories. I think I'd also be asking about compliance. Is he actually taking what he's meant to be taking?
He's
as
taking
he's
everything.
supposed to be?
But this bloke was taking everything, bless him. He was taking everything and trying to do everything that he potentially could on that front. So I think this one's a bit mean, but I'll explain. So patient was known to be very high risk of cardiovascular disease, but he doesn't fit the mold of a typical type 2 diabetic on that front. So he's noted to be on dual therapy. So again, that kind of control in itself. So it's 53 to 58, but he's previously was really well controlled, but seems to have gone a bit pear-shaped on that front. And he's noted to make changes. He's made changes in diet and lifestyle, but it's just not helping. So he's done everything on that front. So this one I was a bit kind of concerned about. And I was like, this doesn't fit the mold because he is a very thin patient being thing. So you got to remember, are you insulin resistant or you're insulinopenic? So this insulin resistance is normally those typical larger patients. Insulinopenic is probably those thinner, slightly more svelte patients in itself. So he was the more insulinopenic on that front. So I sought advice and guidance because I'm concerned about LADA or COVID-induced diabetes that was made worse because of beta cell damage, because something that COVID has done. So it's something just to keep an eye out for and arrange for a GAD antibody test at local hospital. and he came back GAD antibody positive in itself. Was seen in Diabetes Day Unit for assessment and management of LADA in itself. And actually, because of that, he was started straight on to Levemir and Novorapid straight off the bat. So it's just something to keep in mind. If things don't quite sit right, that you've got a patient who's thin and generally really motivated, doing really well, that it may not be them that's the problem. Maybe that their body's just not quite reacting the way that you want to on that front. And repeat HbA1c, again, an ACI in 3 months, came down to 59. ACR was still negligible. So that one's a bit mean, but it's just to put out there that we don't need to just be thinking about medicine and battering out the medicines all the time. The fact that he'd been started on gliclazide, it still did nothing and it was still going and shooting through the roof is the concern. Because if you've got someone with, for example, like LADA, if you're giving them something to go and give them a punch effectively on that pancreas and the pancreas isn't working, no matter how much you give of that, it's not going to be going and doing anything. And it's going to keep soaring upwards. And that's what happened with this patient. So again, would have been completely right. If it was more mature, I probably would have said to go down the side of going and getting a CT pancreas, go and make sure that we're checking those kind of things, make sure we're reviewing those patients to see what's going on and make sure we're not missing anything either. We've got our lovely patient GM, who's a network engineer, long-standing diabetes since 2007, family history of ischemic heart disease, recent evidence of having diabetic retinopathy on his left eye, so having R1. So he's got some changes that are happening in his left eye in itself. 5 years ago, went on the expert program, so really engaged on that front, really reluctant to take any injections because he's needle phobic, refused any form of injectable medication, is not going to take it. Is motivated to maintain his diabetes and control his weight. Last retinopathy screen is up to date, but last done in 2020. And we know that there has been a bit of a delay in getting them done post-COVID, so we need to just make sure we're holding fire on that front. Has been feeling more thirsty since having COVID-19. And previous HbA1c was 48, and now it's jumped up to 104 on that front. So we're a bit like, oh my God, what the hell's going on here? At 104. BMI is 30, weight's 88. HbA1c is obviously 104 on that front. BP is 139. EGFR is 75. His non-HDL R is 2.1. ACR is negligible. Metformin, lisinopril, and simvastatin is what he's on. What are we thinking? Give you my first bit. So, notice to be very high risk on that front, which we know about CV disease, and notice to be on monotherapy. So, individualized target for him on that front would be 53 to 58, ideally, is what we want to be going for. And he's at 104, I think it was.
Silence.
There's always going to be silence. I can always imagine there's going to be silence. Don't worry. I'll go through it itself. So again, for this one, ideally, because patient's symptomatic, we need to reduce it down rapidly. Because could it have been post-COVID? Could it just be that it's gone a bit pear-shaped? So for him, start him on gliclazide 80 milligrams twice a day, and then added in diabetes, dapagliflozin 10 milligrams after about 2 weeks for the heart and the renal protection. In light of symptoms and risk of glucotoxicity, we checked his HbA1c in 4 to 6 weeks. So we did that. So the reason we did this is that once we started him on the gliclazide, I got him to monitor his blood sugars at home. And I could see that they'd gone from being up in the kind of 15, 16s with the gliclazide twice a day. It had gone down into about 8 or 9. So I was thinking, okay, this is better now. So we added in that dapagliflozin and rechecked it 4 to 6 weeks. Obviously counseled him on all of the above. Repeated his HbA1c and it was 64. He'd had one episode of having hypo in itself, where he actually didn't check his blood sugar, but he felt like he was having a hypo on that front. But it was more when he started gliclazide and nothing since being on gliclazide and dapagliflozin, which actually should be worse when he's having that on that front if he was going to. Now, with this patient, actually, there were 2 options here. Now we've actually got another option going forward, because especially in light of the guidance on that's out there, we can give oral GLP-1 therapy to reduce down HbA1c as well if we need to. So back then, advised on the GLP-1, which is a CV protection on that front for Trulicity. And if anyone's ever not seen the Trulicity, it's a joy of me being in my clinic. If you haven't seen the Trulicity, this is what your Trulicity tends to look like. And it tends to be a hidden needle for that reason. What we say a hidden needle is that a patient will see no needle. Everything is loaded into that, and there's no needle on that front. They literally would just switch it on, and then that goes in, and there's no needle essentially on that one at all, on that front. And it's all hidden going forward on that front in itself. So the idea is that it's all hidden going forward. And we repeated his HbA1c when we started this, and HbA1c was down to 55 from a 64. But you could do the same thing now with oral GLP-1s and start with Ribelsis instead, and that would be another option that you could go and consider as well. I think this is my last one, because this is probably going to be more of the type of patients that you're potentially going to see in-house on that front. So patient whose MM is 80 years old, retired homemaker with long-standing type 2 diabetes since the 1990s, lives in a care home, unsure about kind of family history since she's moved there, no evidence of background diabetic retinopathy. She's got dementia, and daughter's got lasting power of attorney on that front if we need to go down that route. She's deemed to be severely frail and approaching end of life, but not quite at end of life at the moment. Reluctant to take any additional medicine, but if it was warranted, she would take it. Lives fairly sedentary lifestyle. Her last retinopathy screen was up to date and carried out in 2022. Her foot check's up to date and is normal on that front. And currently her HbA1c is 72, BMI is 27, weight is 61 on that front, and she is EGFR 48, as well as non-HDL perfect, ACRs negligible, metformin, lisinopril, and atorvastatin. What are we thinking? So she's 79 years old, well, 80 nearly. So 79, 80 years old on that front.
So sort of just manage symptoms, essentially, a couple of people saying don't change anything unless she becomes symptomatic.
Absolutely. So she's approaching end of life. We're not end of life yet. So we think she's going to live for another year, hopefully, she says, at least. But again, very high risk, but potentially approaching end of life. Completely agree with you on that front. She's on monotherapy. Her individualized target would be 53 to 58. Normal weather, but due to frailty, ideally the aging of 70 and getting for asymptomatic. If she was end of life and this was like her last few weeks, we'd be definitely going for managing her symptoms. But she's got some symptoms and we want to go and just try and balance that out on that front. So spot on, everyone. She's asymptomatic at the moment and she's content with her current regimen. So you could just leave her as she is. Absolutely valid on that front. Because I'd want to aim, because she's not quite end of life for 70 on that front, we want to just add in maybe a DPP4, which is acetagliptin, so which will help just to nudge that HbA1c just down a little bit. And that's what we did. We just added in that acetagliptin because we know it just drops it between 4 and 6 millimole per mole. Repeat back came in 3 months, came back to 65. And she's happy with the control. Just look for symptoms and adjust therapy if it's indicated for those reasons. But that was it. So hers at 65, I'm not worried about. We got it below that 70 threshold. We could do that quite easily and quite timelessly without any concerns. And that's me done on that front. So hopefully, she says, that was helpful. And we can do more case studies, or you guys can bring case studies if you'd like, and we could do them that way if you wanted to, and we could have a catch up about that if that's helpful. I'm hoping that's been helpful for you guys.
Certainly been helpful for me. Does anyone have any other questions, cases, anything they want to ask Chandni while she's here? I think there's a bit of typing going on, so hopefully.
You can talk to me, honestly. I don't mind.
Put your cameras on.
Managed to finish my tea and that, though. That was quite fun.
Yeah, we've got a request for your leaflet, if that's all right.
Absolutely. What I will do is I will send it out to you. Absolutely, I can send it out to you. Just to guys, because I know that it's been quite SGLT2 heavy, because that is the big change of now everyone needs to be on an SGLT2 effectively. And we've got a little bit of time. So let me just quickly add this in. just so everyone knows exactly the kind of thing that I'm talking about. Can you see that, Ellie?
Yeah.
Yeah. So basically, I created this SGLT. I will send this to Nisha as well. So it goes and says exactly how SGLT2 works. So it helps to stop reabsorption by blood, and the blood glucose to remain in the urine, so moved in the urine, blah, blah, blah. How they're taken, normally taken and accompanied by water. Important to take your medicine at the same time. So you don't need to take it with food and whatever else. And it will go and test positive for your sugar while you're onto medicine. What I have is I've got the 3 main drugs, and whatever one I'm giving to patients, I highlight so that the patient knows exactly which one they're taking, because otherwise that can be a bit messy. So I tend to highlight the one that I'm giving them. So whether that be if you're highlighting it and then putting it in the notes, so they've got it and then emailing it to them, or if I'm printing it and giving it to them as well. The next thing I've got there as well is kind of what the side effects are, higher risk of what you can go and end up getting. Germs, I wrote, because some patients don't like bacteria infections, I wrote germs. Grow in the body with natural sugar content. And because you're increasing sugar, they can increase your risk of this. Risk can be reduced by increasing the amount of non-sugary fluid that you're drinking when you start the medicine. Severe infections are rare, but you should see your doctor if you've got any signs. Linked to Fournier's gangrene, although extremely low, affected individuals usually have several other medical conditions. And we start with an area of redness and soreness that can spread quickly, and you also feel very unwell, and report this straight away. Key thing being, they start with the redness and soreness. So you tell us in itself as sooner. So if you have any of that, you come and see us sooner and let us check it out sooner. People getting recent sores and ulcers on their feet, so make sure that there's the circulation of the toes and feel cold, can feel a bit colder. Increased risk of amputation, but again, very low on that front. Can increase raise blood chemicals known as ketones, very rarely, but lead to diabetic ketoacidosis. So in people type 1 rather than people type 2, because it's true, it happens in type 1, which is why type 1s don't have this medicine. But symptoms you can include feeling sick, tummy pains, losing weight quickly, very thirsty, breathing difficulty, confusion, tiredness, sleepiness. If you have any of these or any of this itself, you should stop taking the medicine on that front and go and actually speak to a doctor or nurse straight away, or paramedic for that reason as well. On that front, SGLT2, I say this, I'm a pharmacist, I should probably be on that thing, and I'm the one who wrote this. SGLT2s can affect your ability to drive and machinery, so it shouldn't affect any of that. Will not cause your blood glucose to go too low. Who should not be taking if you've got a problem with your kidneys, dehydrated diuretics itself, have any of these problems, herbal things if you're allergic to the medicine, or if I forget to take it as soon as you can. In the case you skip it, take the next one normal. Do not take a double dose if you've missed one, being complete opposite one. And again, the most SGLT2 inhibitor, can you take medication as you've been told? You've been advised to change your diet, stop smoking, regular activity. So I put in a little bit about skincare as well, and make sure you get your skin your checks done as well. So more than happy to share that and get that sent out as well. So I'll send it to Nisha if that's helpful. So you guys have it as well.
That's great. I think it's like you say, it's really helpful sometimes to either physically give or even an AccuRx just to sort of.
Yeah. Well, that's what we do, and it covers you also for CQC. So where it's being started, it covers you for CQC, because CQC look to make sure that that's actually been given out and you've given them the right information. So it covers you that way too. But yes, I will get that forwarded to Nisha as well.
Thank you.
Are there any other questions about diabetes, about anything else? You can say no.
I think it can be a bit overwhelming to start with, can't it? I think